And it's my great pleasure to announce the next speaker, who now, after some initial technical problems, is online now, and it'll be Professor Amitava Banerjee from the UCL in London. And he's speaking on long COVID from known knowns to unknown knowns. And I hope we can manage to bring him online now. Yeah. Perfect, thanks.
Also a consultant cardiologist. Thank you very much to the organisers for the invitation to speak. I have been thinking how to capture all of what we don't know, and I thought I'd use this very well-known expression that Donald Rumsfeld talked about when he was talking about the weapons of mass destruction in Iraq. So these are my conflicts. I'm a clinical academic. I have various research funders, and I'm a trustee of various organisations, including Long COVID SOS, which is a patient-led charity in the UK. So I think one of the problems that we have is one that's rife in medicine, that we work in silos, and when we have diseases that affect different systems, that challenge our communicable versus non-communicable ideologies, then we are stuck in our silos. So silo, for those of you who are classic scholars, is from the Latin and Greek, and that was how we stored corn and kept it separate in different pits. That we can't do when we're affected by a multidisciplinary, multi-system disease that is affecting different countries, and that falls under the realm of almost what we call complexity science. Also, the term pandemic has been challenged by many commentators, that we should be talking about syndemics. Of course, the infectious agent, in this case SARS-CoV-2, the virus is the key instigator, but to ignore the interplay of social determinants of health, of underlying risk in terms of non-communicable diseases and non-communicable risk factors is naive at best. So syndemic, I would say, is how we should look at this. This is what Donald Rumsfeld, the then Secretary of State of the United States, said there are known knowns, there are things we know. We also know there are some things we do not know, but there are also unknown unknowns. The ones we don't know, we don't know. So let me try and use this classification. So known knowns. Well, we know that when I mentioned silos, these three silos of science, evidence, and care often sit totally separately. And whether it's brought about by electronic health record data or by ways of working, this learning health system concept of virtuously linking these three silos is incredibly important if we want to move quickly in this kind of cross-disciplinary challenge. The other known is that this sits on a prevention spectrum like other chronic diseases. So the best way to avoid long COVID is to avoid getting infected in the first place. That goes without saying. But most of our countries are now in a phase where they're not actively pursuing infection suppression. Vaccination is important as a primordial prevention strategy as well. But failing that, it's important to recognize people early, rule out other diseases and pathophysiologies, and try to treat symptoms and move towards a situation where we can actually treat underlying disease and provide rehabilitation for people who need it. This concept I've written about a lot in relation to my home territory of cardiovascular disease. So cardiovascular disease can be a risk factor, can be part of COVID and long COVID illness, and can be an outcome. And that fits nicely into this learning health system framework. So that's a bit of background for you. Now, in terms of the known unknowns, well, in the first wave of the pandemic, this is a pre-vaccination era analysis, and 40,000 people who were hospitalized with COVID and discharged. Yet at 4 months, 12% of them had died and 30% of them had been readmitted to hospital. And there was a good amount of new non-communicable disease, diabetes, MACE, which is major adverse cardiovascular events, chronic kidney disease, and chronic liver disease. This was published in the BMJ. But it's not just hospitalized. Remember, most people with long COVID in all of our countries are non-hospitalized. So their initial illness was not severe enough for them to be hospitalized with COVID. But again, this is analysis in the first 1,200 patients to go through our University College London long COVID clinic, where we see that the functional impairment, which the last speaker, my colleague, was referring to, the impairment that people suffer that's functional, that people are unable even at 12 months to return to work full time who were previously working full time. And this people who were working before who were either retired or not working at all. So even the non-hospitalized group has a significant impairment. We conducted a study called the Cover Scan study. So with colleagues here from Perspectum, which is a company that works before the pandemic in imaging, particularly of the liver, but we developed a rapid multi-organ MRI sequence that can be done in 35 minutes and looks at all the organs except for the brain. And we were doing this in the first wave of the pandemic to try and identify if there was organ impact. And we showed that, again, one of the questions in the last session, that there's a large number of very varied symptoms. The good news is that a good proportion of people get better. So that's the dark blue bars. We followed people up here, I should have said, for 1 year. So 1 year, most people do get better, but a good amount of people still have symptoms at 1 year, whether it's fatigue, whether it's fever, whether it's joint pain. But on the bottom, there are various MRI metrics across different organs. And again, this is showing that although most of the abnormalities are mild, the dark blue bars are still present at 1 year. So there's persistent multi-organ MRI detectable abnormalities. And this study included 500 or so non-hospitalized individuals, and about 60% had single organ impairment, about 25% had 2 or more organs affected, and at 12 months, this was still present in about 60% of that 60%. So this is definitely a cause for concern. In my home territory of the heart, other than myocarditis, which is what most of the scientific community and most of the debate has been concerned with, even outside of myocarditis, 1 in 5 individuals with long COVID had persistent abnormalities at 6 months, and half of those at 12 persisted at 12 months. So on that backdrop, we set up a large national study called Stimulate ICP. The hardest bit in these kind of consortia is coming up with the acronym. I'll take the blame for that. But symptoms, trajectory, inequalities in management, understanding long COVID to address and transform existing integrated care pathways. So we you could say bit off more than we could chew here, but using those frameworks of the learning health system and the integrated care pathway or integrated approaches to prevention, we wanted to take a holistic view rather than biting off one therapeutic question within long COVID. And we did it like that because my co-lead in this project, Melissa Heitman at the top of the slide, is the national lead in the UK for long COVID services, but she set up the first long COVID clinic in University College London Hospital. And the model we have in the UK, when in England now we have over 100 clinics like this. So GPs refer people, GPs, the general practitioners, primary care physicians, will see somebody who's got suspected long COVID. If they think it is long COVID, they will refer to a long COVID clinic with basic investigations such as chest x-rays, such as ECG, such as basic blood investigations. They'll have a full assessment in long COVID clinic, and those that are able to will be referred for rehabilitation after other diseases have been ruled out. So the first work package is to look at usual care in this regard. The second work package is a complex intervention trial where we firstly are looking at whether the cover scan, that multi-organ MRI that I mentioned, helps inform and increase the efficacy of management of people with long COVID. And on the other side, we've got Living with COVID Recovery, which is a digital rehabilitation platform. So those two interventions are part of an integrated care pathway, which people are randomized to in a cluster design at what we call the primary care network level, so that it's part of their usual care. And within this study, we've also embedded a drug platform study, which initially had the antihistamines, loratadine, famotidine, but also it's got colchicine, an anti-inflammatory, and rivaroxaban, anticoagulant, in there. We are following people up for 3 months, 6 months, and then we have data linkage at 1 year, and they would carry on the therapy for 3 months. And fatigue, on the fatigue assessment scale, is the primary outcome, but we have a whole battery of secondary outcomes, both functional, psychological, and physical. I'll speak more to that trial a bit later on. And the third work package is about looking at inequalities in care for long COVID, from referral through to treatment, trying to improve the case finding and referral, because we know some groups and some components of the society are being missed, and comparing with other long-term conditions. This is just to say each of those three work packages has subgroups, and this is a big undertaking across many universities, hospitals, industry partners, and others, including policymakers. So there's epidemiology and informatics in the first work package. There's the trial, both of integrated care and drugs. And in the third part, we have mixed methods approaches to inequalities, from interviews with qualitative methods to Delphi-style analyses. All of the protocols for these parts are published and available online, and you can go to our website. And we're gradually moving towards having results, definitely by the end of this year, if not early next year. So just to summarize the trial, so it's a cluster randomized trial of the integrated care components, i.e. the multi-organ MRI and the digital rehabilitation platform. That drug platform study is at the individual level randomization. There are 6 sites operating around the UK, and we're adding more sites. And this was done within the NHS system so that it can be scalable. It's not just a research study. And as my colleague Melissa Heitman says, that we did this because we're building the plane while we're flying it. Usually you know more about mechanism before you start this kind of drug trial, but whatever we find will tell us something about the mechanism as well. So that's why all of the drugs we've chosen, either drugs that the long COVID community of patients are already using and having some benefit from, but there's no trial data there. So there's the autonomic dysfunction, inflammation, clotting abnormalities, issues with mast cell activation. But what we are still in the hinterlands and the early stages of figuring out is what the underlying disease process is. Is it viral persistence? Is it immunology, inflammation? Is it a metabolic dysfunction picture? To date, we've recruited 800 people. We have over 300 in the drug trial. It's a difficult environment, not just in the NHS, but across health systems. But we're all recovering from a battering over the last 3 years, and that includes issues for our regulators, contracts, colleagues, and so on. So it's not easy to do research in this environment, but we still hope to have recruited over 1,500 people by the end of this year and be able to answer the question for these 3 drugs and for the integrated care pathway. And we're looking to add antiviral arms to this study as well, and looking for funding and support for that. There's lots of variation across the different clinics in the UK, even looking at the 6 that we're operating in terms of clinic design, patient flow, access. And that reflects that we as a health system, and I think that's across different countries, we're focused on the acute phase of the pandemic. And so whatever was left over was what we could tackle long COVID with, whether it's in primary care or whether it's in secondary care. And in the UK, we're lucky we have relatively good national electronic health record data. I'm coming towards the end, but I just wanted to show you some mechanism data that's quite new. So we showed, using data from the UK Biobank, that hepatic steatosis and fibrosis, independently of obesity and other risk factors, particularly metabolic risk factors, increase the risk of infection and hospitalization with COVID. And colleagues in our team have written about the link between the liver and the heart and the brain. Interestingly, when we look at our cover scan study in the first wave, we saw that there was a preponderance of liver impairment. If you look, about 30% of people, whether it was at baseline or at 1 year, had liver impairment, which is higher than what we'd expect in the general population. And in our interim analysis of MRI in the first 200 or so participants, we're seeing the same, if not higher, levels of liver and pancreas impairment. And we're looking at this further, and we're also looking in UK Biobank to see if there's any signal pre-COVID, because these patients obviously haven't been scanned before, but to see what was there before. But we've also got preliminary proteomics data to support this impaired liver metabolism picture. And so what we think of as a post-infectious disease complication, at least in a subset of people, there seems to be some metabolic process going on. And this is interesting because you may be all aware that metformin has been shown in the acute phase of COVID to reduce the incidence of long COVID. It's not been shown in people with long COVID to have any impact on symptoms as yet, but it's opening the door to thinking about metabolic dysfunction. On that theme, in our electronic health record analyses at national level, if you look on the left of this slide, this is 18 million people with COVID, and on the right, just under 300,000 people with long COVID. And we're looking at mortality and hospitalization over 2 years. The red lines are people with established cardiovascular disease. The blue lines are people without cardiovascular disease, but increased risk, be it hypertension, diabetes, or otherwise. This is assessed with this score called the Q-risk score. And what you see is that if you have cardiovascular disease, post-COVID, your mortality and hospitalization is astronomical. It's still high even for the blue line. Interestingly, people with long COVID have low mortality, lower than the overall population, but they have a hospitalization risk which is similar to people with raised cardiovascular risk. And if you look on the right-hand side of the slide, just focusing on people with long COVID, again, it's people with cardiovascular disease and cardiovascular risk who have raised risk of mortality and hospitalization. So the chronic disease and post-infectious link is important. This is looking at the epidemiology of vaccination, and the red lines here represent people who are vaccinated. The darker lines are people. I'm sorry. The red lines are unvaccinated. The dark lines are vaccinated. So people who are in the red lines and unvaccinated have higher mortality and hospitalization in the COVID cohort. And the same is true for mortality in the long COVID cohort as well. This is just for the long COVID cohort, just a zoom in. And it seems that on the bottom, I'm focusing on people with cardiovascular disease. Again, if you're going to focus on a group, people who have cardiovascular disease and cardiovascular risk seem to have a poorer prognosis. There's a huge cost and resource implication of the millions of people with long COVID around the world. In our setting, we've looked nationally and looked at control populations. So the same people, historical self before the pandemic, people without COVID before the pandemic, people who had COVID but not long COVID, and the contemporary non-COVID cohort. And the only one that's more expensive to deal with at system level is the people who have acute COVID, and that's because of the admission and critical care costs associated. People with long COVID use a lot of healthcare resource, whether it's in emergency departments or general practice. That healthcare utilization occurs after the initial diagnosis of long COVID. It's not that it gets less necessarily with time. So that should put fire in our belly to do more research and more improvement to try to find out why that is and tackle this problem. So this is what I'm showing here across our 6 sites, that after the first long COVID clinic appointment, there's still healthcare utilization in both males and females. And this is a very complicated diagram deliberately just to show you that although I've talked a lot about electronic health records, part of the magic sauce is to try and draw out the patterns and clean the data. But here, what you're looking at is in University College London, where we have large-scale electronic health records. We've got vaccination rates, staff levels. We've got the political situation where a lot of our staff are on strike periodically at the moment. There's different resource problems in the system, and trying to superimpose what's happening with long COVID on top of that is not straightforward. So to finish, Chair, I mentioned the learning healthcare system. I think our science needs to be a lot more adaptive and increasingly the communicable versus non-communicable paradigm is out of date. We need to be moving from pandemic to syndemic. For our evidence, we need to be more data-driven and patient-led, and we need to be much more proactive, preventive, and patient-centered in our care. In the UK, there's various policy documents that are alluding to the role of the learning healthcare system. So prevention's best. We've got to zoom out and be wide angle, be joined up, and patient-driven is the only way. Thank you for your time. I'm happy to take questions.
Well, thank you for this really perfect presentation. Learned a lot. Are there questions from the auditorium? Yeah, please.
Thank you. If you say prevention is best, we know so little about post-COVID. How can we do preventive action? How can we actually start preventive action? at a given point. We have to learn much more to be preventive. Are there cues that you see to get into prevention?
Yeah, thank you. That's, of course, the million-dollar question. So infection and reinfection, as I said, things that we've paid less attention to at societal level now. But people who have long COVID, you'll see the people who are most likely to be wearing masks and wanting to get reinfected because of the fear of that. I think vaccination is what I meant. And I also hope that some of what I've shown you about cardiovascular disease and cardiovascular disease prevention are things that we have an evidence-based battery of treatments, both preventive and at the secondary prevention level, which have been neglected over the last 3 years because of health system pressure. Those are indirect effects of the pandemic. In terms of long COVID itself, we're still, so prevention is still in the evidence gathering, the trial stage. And I think we need more in the antiviral space, whether that's Paxlovid and other drugs to be tested. But I think also the metabolic data that I showed you, I would like to see more large-scale trials of some of the existing drugs that are used traditionally in the cardiometabolic space for people with long COVID as well.